Well, hello,
Yes, sir.
everyone. I'm talking to you from Portland, Oregon. So I guess we're all over the United States. So we're going to be talking about Class 2 mechanics, which is finally going to match our skills with moving teeth around. So we've had a lot of problems moving jaws around. So we're going to look at that. So here's the objectives that we want to include clinicians to realize, and it'd be easier if you guys just read these 5 things. Okay, so that's our objectives. So I want to always start with a thank you. These are 2 guys, McNamara and Burstone. Those are my 2 rock stars of ortho. Because McNamara, with his research on what a Class 2 is, and Burstone with very detailed and precise mechanics that we're all using now. So thank you. And this is our title today. So we want to pick up free energy from the face muscles, because the face is an extremely energetic part of your body. It's being used all the time. And then we want to produce curved vectors instead of linear ones, and then just blow away overjet in 4 to 6 months. So that's what you're going to be seeing today. And we'll first half is theory, and then we'll get into these 10 cases to show you. So here's what Dr. Baig looks like. And he invented the Baig bracket that we'll show you pictures of in a minute. But he ended up being a student of Angle. And this is one of the brackets that Baig uses. And Baig used to be as popular as Edgewise. It was when I got out of UC Med Center, I had to learn how to use these, because offices were using this kind of mechanics. And you see the arch wire here? That's called a ribbon arch. And the reason we got named Edgewise is because Angle rotated that 90 degrees, and the wire was then on edge. And the brackets, the wire is 16 round wire. Baig does everything on a 16 round, and it's pinned in with that little notch at the top of the slot there. And it goes through 3 different stages. And this is the end of stage 2. There's a lot, they really like dished in profiles. So most 90% of people were getting 4x extractions in that era. And this is the end of stage 2. So now they have to fix all the tipping that they've created. And they do it with all these springs that are sticking up. You can see them sticking up. Here's a good example, because as these teeth move distally, they tipped inwards. So you have to put some pressure near the gingiva to correct the normal tilt of the central. And even as you close space, these 2 centrals, guys missing laterals, so they really tipped. So you see all the wire bending that they have to do. These are all chair side bent springs that I had to do when I went to Denmark and became an orthodontic instructor there. They were using Baig brackets, just like these. So along comes Dr. Angle. So he's the other side of the coin here, is Dr. Edgewise. And here he is at happy hour, just having some fun with the guys, having a couple shots here. And this is the difference between linear. This is linear. So this is a round wire, like Baig would use, 16 round. And when you move teeth with wires, with a round wire, they tip just like this. So that's contraindicated for us in this era. The irony is, and here's a list of 90% of all your Class 2 machines, these are all using Baig forces. So these aren't edgewise forces that you're using on your brachis. So all your class 2s are tipping everything that you hook them onto. So here's a way to avoid tipping, and you notice there's the wire's on edge and it's in the slot now and it's rectangular. That's able to put force up toward the root of the tooth, which is like the center of rotation up there, and you can correct the tipping, or in this case, avoid the tipping. Stress in my office comes from two big sources, because you have a big staff that take care of a lot of the other things, but making a beautiful set of teeth and then creating the occlusion, which then makes the profile turn out. These are our two responsibilities. And here's a case that needs some help. So this is as bad as you can get on the crowding problem. We got a lateral and crossbite you can see there, plus ectopic eruption of that poor canine. Then downstairs we've got gingival resorption already on this poor 12-year-old. Midline's way off. So this was obviously a 4x extraction case. And in exactly 1 year, she actually accidentally came in 1 year later, and this is what she looks like. And so this is what Edgewise does for tooth mechanics. These are all programmed to get just the right tip and the right torque to be naturally beautiful, like this case is. All done in 18 months, because you don't have any cooperation without a bite problem. So cooperation problems come up next when we're trying to correct an occlusion. Okay, now we're going to do the profile and the occlusion. And here's, people send me slides. This is a first time use of the Vector Pro by this patient. And look at the nice development of the profile. So that's a key feature of what we're talking about today. You can see the mandibular change on this girl without any cooperation from her. And here's a fellow in Brazil, first case, and this is a classic class 2. They tend, as you get overjet, you lose lip seal. And when you don't have lip seal, the lips that are a donut-like muscle do not grow. So there's atrophy of the upper lip. So you have this open mouth kind of look. And then of course the small mandible. So he was able to use the Vector Pro, plugged it in, and look what happened on the right. All the problems went away. The overjet goes away, lip seal comes back, and you can start growing your lip again normally. So let's look at what exactly a class 2 is. We can't pick a system till we really know what the problem is. And there's been very few studies on what exactly a class 2 is. But this was a monumental one, because notice the number of the sample size, 277 12-year-olds or 8 to 10-year-olds participated in this. So with that giant a sample, we've got a real fix on what class 2 is. So let's look at SNA first. That's determining where the maxilla is in the AP direction. And I hope you're shocked to see that only 13% of class 2s have a protruded maxilla. So the next question I want to pose to you is like, why are you giving them a headgear to push distally on the maxilla? So the mandible is the cause of all the class 2 problems we have. So let's move on here. And this is a nasion perpendicular. That's another measure of where this is 12% of our class 2s have a protruded maxilla. So we don't want to put distal forces on the maxilla. This is what that looks like. Okay, and then in the mandible, that's SNB. And sure enough, most of the people, 62%, do have a retruded mandible. So mandibles are the one we want to focus on and to develop, because that's the source of the overjet, is the mandible, not the maxilla. So here's what that looks like. You can see all the mandibular displacements here. And same thing here. Now this is mandibular plane angle. So what happens is, in half our cases, or 48%, we have a steep mandibular plane angle, which is a real red alert for any extrusion of posterior teeth. But you're going to find out in a minute, that's exactly what you've been doing on a high angle class 2, is extruding posteriors. And that leads to a long lower face as the mandibular angle opens up. Okay, we can sort of set up some rules now. So we have a normal maxilla or retruded. We don't want to move them distal. We have a retruded mandible, so we always want to bring the mandible forward, and a steep mandibular plane angle, so we don't want to extrude teeth. So we can set up a little scorecard here, and I've added 2 other features here down at the bottom left. We like to use continuous light forces, and ideally we want it to be fixed, so we know it's going to happen. So let's look at a real popular appliance, a carrier rubber band holder. So these are class 2 elastics, and this is the graph on those. You can see on the maxilla, it's pulling distally, which we already discussed. We don't want to do that. Pulling down on your upper centrals, another crazy thing to do, because they have a toothy smile. So these are real bad things to do. Then we look at the mandible. We're also extruding the lower molars, the 6s. And the only thing good in here is we're bringing the lower jaw forward, which will ultimately correct the class 2. And you can see why people think it's a maxillary problem. This guy's got a normal maxilla. He's showing a lot of teeth because they've fallen vertically, but he's got an SAN that's not even 82. So we've been sort of fooled as we look at these cases. We think we want to push distal on the maxilla all the time, which we shouldn't. And this is what class 2 elastics, so they hook from that upper canine down to the lower molar, and see the rotation force in the maxilla. So it's not only pulling distal on the wrong bone, it is rotating the maxilla to extrude and have a more toothy smile. Then you also see the arrow on the lower right. As you extrude those molars, you open the jaw, and that point goes distal, basically. Also, when you extrude, like in the lower teeth, we're not pulling anywhere near the center of rotation of the tooth. So as you extrude lower molars, you're going to narrow arch shape, which again is exactly what you don't want to do because these guys are crowded. Whereas intrusion, like I suppose a high pull headgear, would expand the arch shape, which then helps our crowding problems. So here's the score for carrier elastics, because it is moving teeth distal and it's extruding teeth, and it is pretty continuous if they wear it. And wait a sec, they do extrude, they don't have continuous force, and they're not fixed. So this gets 1 star. Let's move into headgears, my arch enemy, because a friend of mine had one of the first headgear blindings I ever heard of. So I have almost never used these things. But look at the arrows again at the bottom. We're going distal on the maxilla, and we're extruding it at the same time. And what are we doing to the vertebrae? Well, we've never thought about them, have we? Here's a study done in Turkey in '07. Significant differences in measurements of the morphology of the vertebrae. Well, who reads Turkish journals? So no one in America knows this really. And also in '82, the AAO did a survey of headgear. Huge sample, almost 5,000 people. 41 injuries around the eyes, 7 permanent damage, and 5 totally blind patients from using headgears. Where is this published? India in 2014. That's a lot of decades later. And do we read journals from Bavara, India? No, so people are still using them and just don't know it. And here's an '04 thing published in, I forget what magazine.
Dr. Jasper, it's hard to hear you. Are you near your microphone?
Yeah, I'll just sit closer. Is that colder? I mean, better?
That's perfect. Thank you.
Better. Okay. Yeah, and look at the lower with class 2s, you're extruding those. So if you extrude both the upper and lower molars, look at all the rotation you get in the mandible to make the overjet worse. So here's the headgear store. Totally nothing. It gets a big F, and we should ban them, really. Okay, let's go on to the forces and the Herps, because those, one of their goals is to develop the mandible. So they push along these lines. But again, when you look at the upper, here we are distalizing a normal or retruded maxilla. And we are moving the lower jaw forward though. So that's the good news. So this is what happens. The upper jaw rotates and the mandible, so everything is longer in the lower face, but the overjet went away. But this still isn't an ideal profile. And I'm sorry to say, this is what my first invention did. This is the jumper. See it tilting the occlusal plane, and it's moving distal on the upper jaw. So I shouldn't have done this. Sorry, but you're gonna like the new one. Okay, and one of the issues with all the rigid rod gadgets is that it goes right through the food zone. So how do you think you do a food bolus and eat normally with this big steel tubes blocking the food ball from having any contact with the cheek to push it back in? And this is what most of a lot of my herps looks like. So we used to really enforce the heck out of them with, because you can harness pounds and pounds of force with the mandible. And so these had to be, because there's no flex in here, so you can't set the force. So we had to use stainless steel crowns, lingual arches, palatal archers, and it limits what the change can come. This all has to come from the condyle then. And I don't think that looks that good. It's sort of out of the way, but it isn't. And here's the score on that group. We're all the way up to 2. So what are we calling this? Maybe give it a C or a D+. Okay, let's move on to the current vector. And I didn't know what to do about all these problems for a long time, but I realized the face tends to grow mainly in a vertical direction, except for the condyle. So the maxilla drops vertically, and in a class 2, it usually drops too much. And then similar in the lower, you can see those arrows with the lower teeth erupting there. So maybe we need an appliance to push vertically instead of distally on the maxilla. So that was the first idea I had. Then in the lower, the over-erupted incisors, all the front 6 mandibular incisors are usually 4 or 5 millimeters over-erupted compared to the posteriors in the mandible. So oddly enough, instead of doing, horizontal, I think we need a vertical theta. So it took me a year or so to figure that out until this came along. So this is providing those vertical vectors. It's this, when you don't put it in the tube, imagine this laying straight. Then you grab the little pigtail, slide it in the distal of the headgear tube, and cinch it back. So that whole upper arch now is trying to rotate up through the center of rotation of the tooth, but with only 2 or 3 ounces, you cannot intrude 12 teeth. So there's no effect up there basically. But what we want to do with the front 6 is exactly what that arrow on the lower is doing. Light continuous force on the over-erupted incisors. So you're going to notice that. Also, it's out of the way of the food bolus. So here's someone opening and chewing normally, and you can still, it's out of the way of like a Herp's. It's not crossing right through the food zone. And I thought that was a valuable idea, so I actually patented that idea. Okay, so here's a girl. I just put some vectors on. See if you can see them. So she's a class 2. She's protruding forward. And see that back there? Barely see it. And here she'll protrude again. No, maybe not. Okay, so here's the score for that appliance. And I have to admit I was cheating because we all know the answers. That's the irony. You know that we don't want to move the jaw distal, but we still use appliances that pull distal on it. So this wasn't hard to get an A on this chart. So let's move on and let's go clinical now. So the rest of the lecture is all about treating patients, but I think it's easy to understand the theory behind the mechanics of the vector. So here's Tristan, pretty average overjet, full class 2, 9 millimeter overjet. And want to explain that the curve of Spey looks like a curve. We call it a curve, but it's actually 2 planes. You can see the posterior plane, and then a big step up, that's what, 4 millimeters at least. The front 6 are all at another plane that is not the real plane. That's an artificial plane that the class 2, the overjet, generated. So here's how long it takes to install them. So those bicuspids haven't even been bonded yet. You wait till the overjet corrected. So you slip that little circle on there, there's a slot there, squeeze the slot shut, grab the end of the pigtail, and then just shove it through the end of the headgear tube. So you can see that takes all of 1 minute, perhaps 2, to put one on. I do allow 15 minutes for this appointment though, so I can get mom back and show her everything and talk about it with the patient. So that's in on that side. And so you can see it bending a little there and staying out of the way. So that got installed on November 2nd of 16. And I'm going to show you Centric our test Centric by showing protrusion. So we only have 8 or 9 millimeters of protrusion. So if he can protrude 8 millimeters out in front of his uppers, then I know we're getting a true centric. So here he is. It's a little hard to get kids protrude, but see the big step on the front 6. And I'm trying to get him to protrude. Lowers forward, go, go, go. Nope, just open. Okay, here he comes. Well, he can only go to edge, so that's his full 8 millimeter of protrusion. So here's November. Here we are a month later. Look at the front 6. That step is a millimeter shorter than it was. And he can actually posture in front of the uppers now in 1 month. Here he is at 2 months. Notice the front 6 are all leveled by the vector. The vector leveled the front 6, and look at this, he's out 4 millimeters ahead of his uppers in 2 months. Here we go with 3 months. The lower stopped intruded. I don't know how, but they know how to stop then when they're level. And that's 8 millimeters in front of these. So we're in a true class 1 here in 3 months. But I couldn't believe that, so I left them in. So now we're going to 4 months. Oh, I took them out at 4. But we're going to have them protrude for you. Look at that protrusion. So that is a real class 1. Now I, for the first time, put his lower bicuspids on. And we're into this case all of 13 months. And mother and dad are going, wow, he didn't have to do anything. He's looking like a handsome young man already. What are you up to here, Dr. Jasper? Let's see if he does a protrusion here for you. Come on, there he goes. And that's centric. And I thought I'd show you the other side, perfect class 1. We usually always look at the right side because we're right-handed. But look at the mandibular chains. So that's a nice mandible on him now. And his profile looks normal. And he's been in braces, looks like not that long. Here's the no root resorption. These are light continuous forces, so you don't see any root resorption. And look at this profile. So this is him in 18 months without any cooperation at all. That means all your class 2s can do this. And they do. You're going to see a few more, but that's what happens to all your class 2s. So these are the phases of a vector treatment. You just get in there and don't bond the lower bicuspids, but hook everything up, and every month go into a bigger wire and finally get into a biggest rectangular wire. Then you put in the vectors. They're in there 4 months usually, 5. I don't know if I've ever gone 6. So that's how we get 13 months. And then you get to detail for 11 months. You know, and I used to make a joke is, well, I can't take them off till the payment plan's over, and that's at 2 years. So, but I could have taken them off earlier. So let's look at a few cases. Here's a 7 millimeter full class 2. Very deep bite. You can't even see his lower incisors. So this is him at 7 months. So I've just been working my way through the wires and into my biggest rectangular wire. which should be a 21-25 if you're using the average brackets. Okay, 2 months later. It's hard to get patients to protrude. Come on. There he goes a little bit. Let's go to month 3, see how he's doing. Oh, and at 5 months, 12 months total treatment time, we're here. And I closed up the space. I gave people elastics to wear just in bed, but I don't know if anybody ever wore these. So for some reason, there is no big relapse with this technique. So you can see how good he looks at 17 months. So it's easy to finish a case on time at 24. So this is what you're going to notice all my class 2s look like this. A year later, is it stable? Can it happen this fast and be stable? Well, it is. Shocking to me, but all the cases are just like this. And here's a head film. So let's look at the maxilla first on the right. Look what happened. Nothing. We don't want to do the maxilla. But then look at the, I didn't trace this. I sent them off so they could be objective. And he apparently didn't know how to superimpose on the lower jawline. So, but you can see very little tipping there of anything, 2 degrees maybe. But look at the left, the profile on the left. Look at the nice mandibular profile, soft tissue change with this, and the mandibular advancement that occurred spontaneously. Okay, we're going to show you some short examples here, but you've been able to see what happens on the head film. So here's a girl came in, toothy upper smile, gummy smile, and class 2. 12 months later, I put the bicuspids on again, and I was in the mode of overcorrecting a little bit. And so you can see I'm edge to edge here, and it's just sitting there. It's not relapsing. So you don't have to do that. You just go to class 1, take them out. It could be 4 months. And then bond your bicuspids and then start detailing. Here she is at 12 months. Look at that beautiful smile, nice. Now we can see her lower teeth. So beautiful girl. Look at this, mandibular growth. Okay, this guy has a large overjet, you can see. Look at that, 11 millimeter overjet and some really wild front teeth. 1 month on the vector, so I straightened him out through all the little wires, and this is my biggest rectangular. So at 1 month, his overjet is going away already. Here's 3 months. He's edge to edge. And that space you see on the lower right, I wanted that to be there. That's the baby canine. So I have to get a canine and a bicuspid in there. So look where he is at 3 months. So this is one of my early ones. I'm going, I can't take these out at only 3 months on an 11 millimeter overjet. But you can see the poor guy's got a traumatic occlusion on that right central. When he opens and bites again, maybe you'll see it. Come on, watch it move. See it move? So that's not a fake bite that he's doing for the office. He's always in that, and it's beating the heck out of his poor upper centrals. 4 months, took it out. So that's 11 millimeters in 4 months on a 2x4. And its final models. I was really proud of this, this result. You know, everything is looking beautiful. All he has to do is wear his retainers and everything could erupt into maybe not having a phase 2, but he wasn't that kind of guy. He never put his retainers in. So here's his before and after. So you see it was just a 14-month result, but he never wore them. I finally got him to come in at 7 months, and you can see the front starting to relapse, but look at the molar. When I looked in here and looked distally, I went, wow, no retention at all on an 11 millimeter overjet. And this guy's got a class 1 molar just sitting there. So then he vanishes again. We call him, the front office calls him every month. Nothing, no response. 3 years later, he thinks he might need a phase 2. So he comes in, no retention at all. For 3 years, you see the total relapse on the poor incisor, but look at his posteriors. All in 4 months on the vector. Okay, here's another young person, but he has all his teeth, Josiah. 13 months later, looks like this, and I've just bonded up his lower bicuspids. Another large overjet. 13 millimeter overjet. First month on the vector, see that deep bite? Huge overjet and deep bite. Month later, overjet's going away. Month 2. And month 3. Isn't that looking pretty good? Well, that was a big overjet to go away in 3 months. Okay, that's his before and after. Look at that change without this guy doing one thing for me. So if you have cooperation problems in your office and people not wanting to like headgear, this is definitely the answer to overjet. Okay, here's Haley starting. 11 months later, bonding the bis and vectors are out. Jeremiah, massive 14 millimeter overjet. So much overjet, see that upper left first bi? That's in reverse crossbite. And this is one of the early cases, so I don't have step-by-steps, but here he is, 2 years without him doing anything. And he is now out of braces, looking good. And check the mandibular development here. Huge change. This is the longest I've ever left vectors in was 6 months on this guy. Usually it's 4 or 5, but it's still in that 24-month treatment time because that's what your payment plan is set up for usually, 24 months. So you all want to wrap that up just like this with this tremendous mandibular change. Okay, here's Adam, 13 months, same story. Profile change, mandibular change, not maxillary change. Okay, a couple more cases, and then we'll open it up to questions perhaps. This girl was rather excited about getting her braces on. So she's got some pretty crazy front teeth, and she's embarrassed about them. But look at the points on these guys. Wow, she is dangerous. 9 millimeter overjet. So here's that side view. 1 month on the vectors. See the canine, watch that front 6 go. All the front 6 are at least 4 or 5 millimeters over erupted. So let me go on here to 2 months. Look, they're level. All 6 have leveled. Just because there's intrusive force vectors that we're using that are delivered to the anteriors, and her overjet is disappearing. And here she is now at 5 months. I've taken the vectors out, but look where she is. Look at the protrusion. So that's protrusion. That's true centric. Okay, 18-month case. Why go on to 24? So I've started getting them out of jail, I used to call it, out of braces at 18 months, and just beg and tell mom, no, keep going on those payment plans, even though she's out of her class 2 correction. Okay, so here was her final models, and no stress on anybody, patient, the parents, or you. 14 months later, no relapse. Beautiful looking result, and it's extremely variable because I've been brought up to not believe in quick changes, that they would just relapse all the time. But this particular one never has. Okay, let's see. So that's some nice changes on her. Okay, the last case, which actually was the first case, this guy, I didn't have an office when I perfected the Vector in Vector Pro. And so I opened an office and offered a free treatment to a local primary school near my office. This guy comes in, 16 millimeters. I go, oh my God, what have I done here? That's the biggest overjet I've seen in my life. You know, I thought 14 was big, but this is enormous. And he never brushes his teeth. He's got a stainless steel crown on this molar, and his pedodontist put a little plastic filling on his upper right central. So, same old story. Bond everything. I do band the molars though. So I forgot to mention that probably. We don't want them breaking off in the middle of treatment. So I band the molars and then bond everything else except the lower bicuspids. 27 months later, simply because he flunked or failed 6 months of treatment, this would have been done on time. And I can't show you steps because I didn't know this was going to happen. But that's the worst case you could get, is a non-compliant patient with a huge overjet. So even that is treatable now. And his final records. And look at the expansion. This is sort of organic expansion, just with that just a few pounds of pressure, 2 or 3 pounds or ounces. I mean, will give that sort of reshaping of the upper teeth, a little bit of expansion. And tremendous change. This changed this guy's whole life. He was flunking out of school. Now he's gone on to junior college, and it's really nice to do that for people. And a year later, of course, he never wore his retainer. No relapse, even without retainers. So it's been a real fun tour with this appliance, and I hope you enjoy it too. Let's see what's left. Here he is. Big changes, no gummy smile on the upper. And we can actually see his lower teeth. Yep, got my glasses on and his lower teeth are there. And that was only in there for 6 months, that phase of the Vector Pro, just 6 months. So this is kind of a summary that I'll let you read. And I think we're going to be able to have questions. So we'll try to get organized here for some questions. And oh, there's one other application that you're going to like. I think you've read all those positive things. Look what else. Since it's a light machine, you can run them on plastic. You can run aligners. All you need is a headgear tube in the plastic and this little sliding wire also embedded in the plastic. And I don't have any class 3s, but this is just a model flipped over, but you could even treat class 3s with this appliance. You just put a tube on the lower molar and a little sliding wire area on the upper. And this is an adult with sleep apnea. So this the lab made on basically a Holly sort of design here with an Adams clasp and the little sliding wire there. And if you posture an adult forward with sleep apnea, they snore a lot less, or at least won't choke up and die during the night. And here it is. So that's even possible to use in adults. All right. I want to thank you all for being interested, and I hope you learned a lot doing it this way.